Okay, in our video series of emergency medicine and gastroenterology lectures, in this video we are going to talk about acute pancreatitis. A 35-year-old chronic alcoholic comes to emergency department with severe epigastric pain. The epigastric pain is very severe. The patient has consumed large amount of alcohol in the last few years, and now the patient has epigastric pain which is associated with nausea and vomiting. The epigastric pain is radiating towards the back of the patient. Patient cannot lie down straight on the bed because the pain worsens on lying down straight. So the patient is holding the epigastric area and leaning forward like this. When you perform serum amylase and lipase levels in this patient, the serum amylase and lipase levels are highly elevated. This is a classical presentation of acute pancreatitis. Now, what is acute pancreatitis? How do you diagnose it? How does it present? And how do you manage it in emergency department? Today, we'll talk about it in detail. First of all, what is acute pancreatitis? Acute pancreatitis is an acute condition of diffuse pancreatic inflammation and autodigestion of pancreas, which presents with abdominal pain and raised pancreatic enzymes. Now remember, pancreas produces enzymes that cause digestion of the food. But in acute pancreatitis, instead of digesting the food, those enzymes are digesting the pancreas. That is called as acute pancreatitis. And it presents with raised pancreatic enzymes since there is auto-digestion of pancreas going on. That damage to the pancreas releases that enzymes, and those enzymes are present in blood with amylase, lipase levels elevated in blood, raised pancreatic enzymes associated with auto-digestion, caused by auto-digestion and inflammation of the pancreas. That is called as acute pancreatitis. Now coming to the etiology of acute pancreatitis. In the etiology of acute pancreatitis, we want to know that what is causing the auto-digestion of the pancreas from its very own enzymes. To understand that, the most common cause is gallstones. In 40% of the cases, you will see gallstones as the cause of acute pancreatitis. To understand it, you need to understand the basic anatomy, that gallbladder opens into common bile duct, gallbladder produces bile and that enters the common bile duct, and common bile duct is joined by the pancreatic duct. The pancreatic duct which is producing the pancreatic enzymes. This is the pancreatic duct and the common bile duct join each other at ampulla of Witter, and they have a common opening into the GI tract. Now, if a person is suffering from gallstones, that patient can have gallstones dislodged from the gallbladder, and those gallstones can travel in the common bile duct and they get stuck at the ampulla of Witter. Now the pathway of pancreatic enzymes is blocked. The duct of pancreatic enzyme is blocked, and the pancreatic enzymes are now backed up in the pancreas. The pancreatic enzymes are backed up in the pancreas and they get activated within the pancreas. And when they get activated within the pancreas, they digest the pancreas. They eat up the pancreas. That causes acute pancreatitis. Gallstones is a common cause of acute pancreatitis. Second common cause is ethanol. Alcohol damages the pancreas and causes acute pancreatitis. Trauma is an important cause of acute pancreatitis, especially in children who are wearing seat belts on their epigastrium. And when if an accident takes place and that seat belt puts pressure on the epigastric area and puts pressure on the pancreas and damages the pancreas, resulting in acute pancreatitis. Steroids can cause acute pancreatitis. Mumps, autoimmune destruction of pancreas, scorpion sting can cause acute pancreatitis. Hypercalcemia with calcium levels greater than 10.5 milligram per deciliter. The calcium acts as a catalyst and it activates the pancreatic enzyme and results in autodigestion of the pancreas. Hypertriglyceridemia with triglyceride levels greater than 1000 milligram per deciliter can cause acute pancreatitis. ERCP is a diagnostic and therapeutic procedure done by gastroenterologists, can cause acute pancreatitis. Drugs, important drugs include azathioprine, sulfonamides, loop diuretics, thiazide diuretics, steroids, valproate, didenosone, protease inhibitor, estrogen. These drugs can cause acute pancreatitis. You can remember it with the simple mnemonic, get smashed. Now coming to the pathophysiology is just the same. The pancreatic duct gets obstructed, and when the pancreatic duct is obstructed, the enzymes are backed up in the pancreas and they get activated within the pancreas, and they result in autodigestion and destruction of the pancreas. And whenever there is autodigestion and destruction of the pancreas, the immune system gets active. Immune system wants to clean up the debris, clean up the digested material, but in the process of cleaning up the digested material, it releases inflammatory cytokines, it releases inflammatory cells, and sometimes this immune response also causes organ failure in these patients. The inflammatory cells get attracted, they release cytokines and results in inflammation of the pancreas, and sometimes this inflammation is to such a severe extent that it results in organ dysfunction. It results in acute respiratory distress syndrome. Now, when the immune system gets activated, it releases cytokines, and those cytokines cause capillary leakage. They cause vasodilation and leakage of the capillaries. Whenever there is vasodilation, there is hypotension. And when there is hypotension, the heart tries to pump more and more blood, and there is tachycardia with hypotension. The skin of the hands and arms will be flushed and warm because of the vasodilation. There is excessive vasodilation, hypotension, and tachycardia. That is the classical presentation of distributive shock and multi-organ failure. That's why the immune response to clean up those digested materials of pancreas even results in multi-organ failure of the patient. Now coming to the clinical presentation of acute pancreatitis. The clinical presentation of acute pancreatitis is very simple. The patient has constant severe epigastric pain that is radiating towards the back. Patient pain is worse after meals, and it is worse when the patient lies down straight. So the patient is holding the epigastric area, patient is leaning forward like this, and there is severe sharp epigastric pain which radiates towards the back. It improves on leaning forward, and it is associated with nausea, vomiting, and fever. On examination, what you will see is due to the immune response, there will be tachycardia, hypotension, inuria, oliguria. Since the kidneys are not receiving blood due to hypotension, there will be inuria, oliguria, with or without jaundice. When the liver gets damaged, it causes jaundice. On abdominal examination, what you will see is that since an organ of the abdomen is getting damaged, getting inflamed, there will be tenderness, guarding, distension, ileus, stasis of the gut, ascites on abdominal examination. On the skin findings, what you will see is that when these enzymes are released from the pancreas, these enzymes will be traveling in the blood and they will be damaging each and every organ. And when they get into the skin, in the abdominal skin, they cause damage of the subcutaneous tissue. They digest the subcutaneous tissue and they cause bleeds from the capillaries. Those bleeds from the capillaries look as purplish discoloration of the skin in the flanks. That is called as Gray Turner sign, where there is purplish discoloration of the flanks due to the digestion of the subcutaneous tissues and micro bleeds. If that digestion of subcutaneous tissues occur around the umbilicus, that is called as Cullen's sign. And if it occurs around the inguinal area, that is called as Fox sign. And it occurs basically from these pancreatic enzyme digestion of the subcutaneous tissue. Now coming to the diagnosis of acute pancreatitis, whenever the patient presents to you with these signs and symptoms, the first thing that you need to do is that you have to order the pancreatic enzyme levels. In serum, the pancreatic enzyme levels will be elevated, amylase, lipase will be elevated. Diagnosis is made if 2 out of these 3 things are fulfilled. The characteristic abdominal pain, epigastric pain radiating towards the back with elevated pancreatic enzymes, amylase and lipase. And the third thing is characteristic finding on cross-sectional imaging, contrast enhanced CT. Now I'll come to the third point in a while, because CT is not needed in all the patients for diagnosis. We'll reserve the CT for the complications. We'll use the above 2 characteristics to make the diagnosis of acute pancreatitis in most cases, and we'll reserve the CT for the complications of acute pancreatitis. And when you perform the serum lipase levels, you will see that the serum lipase levels are elevated 3 or more than 3 times the upper limit of normal. This is highly indicative of acute pancreatitis, and it is very sensitive as well as specific test for acute pancreatitis. Serum amylase is also performed, and you will see that serum amylase is also elevated 3 times or more than 3 times of upper limit of normal. But remember, as compared to serum lipase, serum amylase is less sensitive and less specific. Serum lipase is more specific for acute pancreas because it is only produced from the pancreas, while serum amylase can be produced from many other parts of the body, so it is less specific. To determine the severity, when you have the patient of acute pancreatitis, you took the history, you think that it is acute pancreatitis, you perform the serum amylase and lipase levels. With that, you also send the labs for CBC, basal metabolic profile, electrolytes, RFTs, LFTs, glucose levels. You perform the ABGs. Why do you perform the ABGs? As I said, when these enzymes are released from the pancreas and these enzymes travel in the body, they damage the organs, and when they damage the lungs, they cause acute respiratory distress syndrome. So to assess the function of lungs, we perform ABGs, that whether oxygenation of blood is normal or not, whether the enzymes have now affected the lungs or not. LDH is an inflammatory marker to assess the severity of acute pancreatitis. Inflammatory markers and serum calcium. I'll come to each one of them in detail. With these tests to diagnose the cause of acute pancreatitis, as I said, gallstones is a very important cause of acute pancreatitis. To diagnose the cause, you perform the abdominal ultrasound to look for the stones. So you perform serum amylase lipase levels, you perform the abdominal ultrasound, and you perform the other lab markers that I mentioned to assess the function of the body. And whenever there is diagnostic uncertainty, when you have performed the serum amylase lipase level and the serum amylase lipase levels are normal, but you are quite sure that that patient is suffering from acute pancreatitis, in that diagnostic uncertainty, you can go for contrast enhanced CT scan. But remember, contrast enhanced CT scan is not a first line investigation that we perform for the diagnosis of acute pancreatitis, because contrast enhanced CT scan does not show changes in the morphology of pancreas in the initial few days when the patient is having acute pancreatitis. It takes almost 5 to 7 days for those changes to appear on CT scan. So till that time, we have already managed the patient. But for academic purposes, you can remember that contrast enhanced CT scan can be used in diagnostic uncertainty. But remember that contrast enhanced CT scan is usually reserved for the complications of acute pancreatitis, because when we will study the complications of acute pancreatitis, in that you will see that whenever those complications of acute pancreatitis can be easily diagnosed on CT scan. On CT scan, what you will see is that there will be pancreatic swelling on the pancreas, and damage to the pancreas will be evident on CT scan. If the patient cannot have contrast enhanced CT scan, or if there is any contraindication to contrast, like patients with renal failure, in those patients you can perform MRI. Now coming to the investigations, the supporting investigations, we had the patient of acute pancreatitis, we did amylase lipase levels, we did abdominal ultrasound, and we did certain labs. Now the labs are back. In the labs, what you will see is that the CBC will show increased hematocrit. Why will there be increased hematocrit? The increased hematocrit shows that there is third space loss of fluid. As I said, the inflammatory mediators are released in acute pancreatitis, and those inflammatory cytokines will cause vasodilations and increase capillary permeability, and the fluid will move out into the third space. That will cause a hemoconcentration and increased hematocrit. The WBC count will be elevated, and it is a marker of severity of acute pancreatitis. The basal metabolic profile will be deranged. The most important one is blood urea nitrogen, the BUN level. Blood urea nitrogen will be elevated, and it shows the damage to the kidneys, and it is an important marker of severity in patients with acute pancreatitis. Creatinine levels, lactate levels will be elevated because there will be acidosis. Blood glucose levels will be elevated because it is a stressful condition, and there will be hyperglycemia. And with that, whenever there is damage to the pancreas, the insulin production, the insulin control is also damaged. The endocrine function, endocrine part of the pancreas is also damaged. That will result in hyperglycemia. LDH levels will be elevated. It is a marker of severity of acute pancreatitis. Serum triglyceride levels are also performed, because as I said, serum triglyceride levels, if they are elevated, they can cause acute pancreatitis. So you do the fasting levels, and you measure promptly after the presentation of the patient, because if the patient goes into the fasting stage, then the serum triglyceride levels will normalize. So you do it initially as soon as the patient presents. You perform the LFTs, and in LFTs what you will see is that if it is the biliary cause, if there is cholestasis, then the ALP level and gamma glutamyl transferase levels will be elevated. And if the ALT is greater than 150 and AST is greater than 3 times the upper limit of normal, it suggests most likely it's the biliary cause, it's the gallstones that are causing acute pancreatitis. And you also send serum calcium levels, and when you receive the calcium levels report, you will see that there will be hypocalcemia. Why does hypocalcemia occurs? Because the serum amylase that was released from the pancreas, that amylase digested the fats in the body, and fatty acids were formed. The fatty acids are circulating in the blood, and those fatty acids love calcium. They love calcium, and they bind calcium, and they reduce the calcium levels, and there is a hypocalcemia due to saponification, combination of fatty acids with the calcium. And when there is a hypocalcemia, you should also measure the magnesium levels, because hypocalcemia is associated with hypomagnesemia. Other than that, you also measure serum calcium levels to see that whether elevated serum calcium is causing acute pancreatitis or not, because as I said, sometimes hypercalcemia can cause acute pancreatitis. So for that purpose, you also measure serum calcium. The second purpose is that acute pancreatitis, be it any cause, it usually causes saponification and lowers the calcium level. So you measure the calcium level in acute pancreatitis. You also send inflammatory markers, and CRP will be elevated, procalcitonin levels will be elevated, interleukin 6 will be elevated. These are all the inflammatory markers that show that there is inflammation going on in the body. An important point to remember is that elevated level of serum amylase lipase are useful for the diagnosis of acute pancreatitis, but their elevated level do not correlate with the severity, that you say that they are elevated in the thousands, so it is more severe, and if they are in 800 or 900, then it is less severe. No, it's not like that. They do not correlate with the severity. They are only used for the diagnosis. Another important point is that you measure serum triglyceride levels promptly after you make the diagnosis of acute pancreatitis, because as I said, we need the fasting sample of triglycerides, because hypertriglyceridemia can cause acute pancreatitis, and we want to catch hypertriglyceridemia, and for that you have to take the sample before the patient is NPO, nil by mouth. Before putting the patient on fasting state, you take the sample and send it to the lab, because once the patient has started the fasting period, the triglyceride levels will normalize. Hypercalcemia can cause acute pancreatitis, but once the acute pancreatitis has taken place, the hypercalcemia will be converted to hypocalcemia because of the saponification, because of the binding of fatty acids with the calcium. So you take the calcium levels initially as soon as possible, because in the later stages there will be hypocalcemia due to the saponification process, as I explained. Now, once you have the patient of acute pancreatitis, you did all these labs, you diagnose that that patient has acute pancreatitis. Now you classify the patient, that what kind of care is needed, whether that patient needs an ICU admission, whether that patient needs to be treated in the emergency department, or that patient needs to be treated in the ward. For the severity assessment, there are certain criteria: revised Atlanta grades of severity, Ranson criteria, Apache 2 criteria, bicep criteria. These are certain criteria that you don't need to memorize. The most important one among these is, and most commonly used in the wards, is Ranson criteria. So you need to know a little bit about the Ranson criteria and what are the markers that are used. You don't need to exactly memorize each and everything out of it. Coming to revised Atlanta grading criteria, it divides the patient into mild, moderate, and severe category. If there is no organ failure, no local or systemic complication, it is mild. If there is persistent organ failure even after 48 hours, that is severe acute pancreatitis. And moderate is the one where there is transient organ failure less than 48 hours with local or systemic complications. An important point to remember is that at the time of presentation, if the patient is having organ failure, if you check the blood pressure and the blood pressure is down, if the labs are highly elevated, if there is organ dysfunction, how do you see organ dysfunction? When you get the lab reports, all the labs will be deranged. It shows that there is severe organ dysfunction going on. And if at the time of presentation the patient has already developed organ dysfunction, that patient is a severe case of acute pancreatitis. Patient presenting with organ failure or within the first 24 hours of admission should be classified as having severe pancreatitis. Now, Ranson criteria is the most important criteria, which is most commonly used at admission. You check the age, WBC count, blood glucose level, serum LDH, and serum AST. And if these things are elevated like this, you give the points to this patient. Each one carries 1 point. After 48 hours, you again repeat the labs and you take the data and you apply the Ranson criteria. If the hematocrit decrease is greater than 10%, BUN increase, serum calcium is low, hypocalcemia, fluid sequestration means the fluid losses. You are administering fluids to the patient and the output is very low, there are increased fluid losses. A serum base deficit, the bases are deficient because there is acidosis, increased acids in the body. You score the patient, and if the score is greater than or equal to 3, then there is high risk of acute severe pancreatitis in that patient. That patient is classified as having severe pancreatitis. Bedside index of severity of acute pancreatitis uses all these things. Remember, the single most important investigation is the BUN, blood urea nitro. If you do not have any other investigations, you can simply use blood urea nitrogen to assess the severity of acute pancreatitis, because the kidneys are the ones that get affected first and the BUN changes will appear earlier, and it can be used to guide the treatment of the patient. Bicep score greater than or equal to 2 indicates severe pancreatitis. Now, coming to the treatment of acute pancreatitis, you received the patient with severe epigastric pain in the emergency department, pain radiating towards the back. You thought that this is acute pancreatitis. You sent the serum amylase lipase levels, and the amylase lipase levels are elevated, and you diagnose the patient as the case of acute pancreatitis. Now, the next thing that you do is that you ask the patient to stop any oral food intake. You make the patient nil per orally, nil by mouth. The patient stops any oral food intake, and what you do is that you give fluids. Just imagine acute pancreatitis as if the pancreas is on fire. The pancreas is burning, and what you do is that you throw water on something that is burning. The only treatment, the only management is fluid resuscitation in the patients with acute pancreatitis. In the first 24 to 48 hours, the only effective treatment is fluid resuscitation. When something is burning, you put water on it. You never put more food onto it. So you put the patient on nil per oral. The patient is not taking any food now. The patient is receiving fluids to put away the fire. So the only effective treatment in the first 24 hours is fluid replacement. You give Ringer lactate solution 1.5 ml per kg per hour with 10 ml per kg bolus in the patients who presents with hypovolemia. Now remember, when you are giving these IV fluids, you do not need to be over aggressively giving IV hydration, because remember, as I said, these patients are usually having capillary permeability. Their capillary permeability is increased due to the inflammatory process in the body. And when the capillary permeability is increased, there is increased chance that the more fluid you are giving, that fluid and is entering the third spaces of the body. So while you are giving the fluid replacement, you must be cautious that that fluid replacement should not be so aggressive that that fluid is getting out into the third spaces of the body. So the fluid replacement must be targeted, and you keep examining the patient that that fluid is not developing edema, the patient is not developing pulmonary edema, edema in the feet. You keep examining the patient, that you keep looking for the signs of fluid overload, because you do not want to overly aggressively treat the patient with fluid replacement and that patient goes into fluid overload states. You give the targeted fluid therapy so that you maintain the normal vitals. You limit fluid resuscitation after 48 hours, and you monitor, and when you are giving the fluid replacement therapy, you monitor the heart rate and you keep the heart rate below 120 beats per minute. You keep the mean arterial pressure between 65 to 85 mm of Hg, and you try to bring the urine output to 0.5 to 1 cc per kg per hour. In the process of fluid replacement, this is your target. But do not overly aggressively rehydrate the patient that that patient goes into a fluid overload state. Now, when the patient is nil per oral, patient is not taking any oral food, and you have started the oral rehydration therapy, now repeatedly you have to perform certain labs to see that whether the patient is improving or not. whether the hematocrit is now normalizing or not. The hematocrit was over concentrated. You see that BUN levels, the most important levels, whether BUN levels are normalizing or not, the creatinine levels, the electrolytes. In electrolytes, you look for hypocalcemia. If there is severe hypocalcemia, you treat that. And you see the serum glucose levels hourly. So you are hydrating the patient, and with that you are also keep checking the labs, that whether the patient is responding to fluid resuscitation or not. If the patient is having hypocalcemia, if the ionized calcium is low, and the patient or if the patient develops the signs of neuromuscular irritability, which is the chopstick signs, the spasm of the mouth, the spasm of the arm when you are checking the blood pressure, these are the hypocalcemia signs. In that case, you replace calcium, because as I said, in acute pancreatitis there is saponification and hypocalcemia. The patient is nil per mouth, the patient is getting fluid replacement, but the patient is in pain. You need to control the pain of the patient, and in the pain control, we prefer opiates. NSAIDs can be used, but you have to look that whether the BUN level or the renal function tests are normal or not. Usually these patients of acute pancreatitis are having organ dysfunction and the renal function tests are deranged. In that condition, NSAIDs can worsen the renal problems. So NSAIDs are avoided, and we prefer opiates, because opiates will not affect the kidneys. NSAIDs can affect the kidneys. So opiates are used IV hydroxomorphone 0.2 to 1 mg IV every 2 to 3 hourly, or IV fentanyl bolus dose 20 to 50 microgram can be used. Meperidine is favored over morphine. You never give morphine in acute pancreatitis, because it is always the wrong answer in acute pancreatitis, because morphine causes contraction of sphincter of Oddi, and it further blocks the passage of the pancreatic duct. The pancreatic duct pathway is already blocked, and it further causes contraction of the sphincter of Oddi and further blocks it, and it aggravates acute pancreatitis. So meperidine is preferred. Dose of 50 to 150 mg IM every 3 to 4 hourly is given. The patient is nil per oral, not taking oral food. We gave the fluid resuscitation. We controlled the pain with opiates. Now we control the nausea and vomiting with antiemetics. If the patient is having nausea and vomiting, you give ondansetron 4 to 8 mg IV as needed, metoclopramide 10 mg IV or IM as needed. Now coming to the nutrition. In the nutrition, you ask the patient to stop taking any oral food. The patient is nil by mouth. The patient is not taking any food. The moment you realize that that patient is having acute pancreatitis, the first thing that you should do is that you ask the patient to stop taking any oral food. You tell him that your pancreas is on fire and that fire needs water to put away that fire. You throw water onto it. You never put more food onto it so that it burns more. So you stop the oral food and you put water onto it with fluid replacement. That is the only management of acute pancreatitis. Now you have stopped the patient from taking the oral diet, but that patient asks you that, doctor, when can I restart my oral food? It depends upon the severity. In the absence of ileus, nausea, vomiting, and if the patient is saying that he is hungry, that is the biggest point that you restart the oral food. Because previously the guidelines said that you keep the patient NPO for a longer period of time, but now the newer guidelines say that if it is less severe, if there is no ileus, if there is no nausea, vomiting, if the patient is hungry, you give the food. Because if you keep the gut NPO for a longer period of time, that gut can go into stasis. And when the gut is in stasis, when the gut movements are stopped due to absence of food in it, there is increased chances that infections will grow and those infections will further spread to the body. So to prevent the complications, the newer guidelines recommend that as soon as the patient is hungry and as soon as you feel that the pancreatitis is less severe, you restart the food. You can initiate within 24 hours. You give low residue, low fat diet, and you can start from clear fluid and you can shift the patient to solid food if the patient is hungry or if the patient is not having any nausea, vomiting or ileus. When the patient feels hungry, that's the biggest start point that you should start giving food. Early enteral feeding decreases the risk of infectious complication. As I said, when the gut is empty for a long period of time, the motility of gut stops, the gut goes into stasis. And when the gut goes into stasis, there is increased chances that infections will grow. So you keep the gut running After 24 hours, what you do is that you start giving food to the patient. If the patient is not having any nausea, vomiting, you start giving food so that the gut starts running and there is less chances of infection in the patient. Complete bowel rest no longer recommended. If the patient is having severe pancreatitis, severe nausea, vomiting, postprandial pain, in that patient you cannot start oral food as soon as possible. In such patients, you keep the patient nil by mouth for at least 4 to 5 days. But after 5 days, you give an attempt, you ask the patient that whether you are feeling hungry now or not, whether do you want food or not, because after 5 days there are so many days have passed and that patient has not eaten anything. In that patient, after 5 days oral diet should be started, and if patient cannot tolerate oral diet, what you can do is that you can start enteral feeding through NG tube, through enteral tube directly into the stomach. In that patient, you after 5 days you start giving food because you do not want stasis of the gut for a longer period of time. After the 5th day, you should start food. If the patient cannot take oral food, you give the food by NG tube, or you give the food directly into the stomach by enteral tube feeding. High protein, low fat formulas are present, peptide, such formulas are given to these patients. Antibiotics are not indicated. They are only indicated if there is any evidence of infection in these patients. 20% of the patients develop infection. In the complications, we'll study that the patients develop infection. In those patients, only antibiotics are needed. If there is deterioration in the clinical status after 72 hours, you must go for contrast enhanced CT scan, because as I said, contrast enhanced CT scan was not the first line of investigation. We diagnose the patient with serum amylase, lipase and the clinical presentation, and if after 72 hours the patient is deteriorating, in that patient you go for CT scan and you look with that what is the status of pancreas. Now this was the management of acute pancreatitis, but you also need to investigate the cause. You need to treat the cause which resulted in acute pancreatitis. If it was the gallstones that were obstructed in the ampulla of Vater, you go for therapeutic ERCP, in which you get inside the ampulla of Vater and you take the stones out through an endoscope. That is the ERCP procedure. Urgent ERCP is only needed if cholangitis is present. Otherwise, you let the fire stop. You treat the patient in the acute inflammatory stage in acute pancreatitis and you wait for some period till the time patient is stable, and then you go for the treatments of underlying causes. Cholecystectomy is done after the patient has recovered from acute pancreatitis. Almost after 6 weeks you go for cholecystectomy. If the patient is having hypertriglyceridemia, you treat it with insulin therapy. Insulin pushes the triglycerides into the fats and it reduces the triglyceride levels. Plasmapheresis can be done. Hypercalcemia must be treated. If it is alcohol induced, alcohol must be stopped, and you also check magnesium and phosphorus level, and vitamin supplementation must be given to these alcoholic patients, because usually these chronic alcoholic patients have low magnesium levels, low phosphorus level and low vitamins like thiamine. When the patient is in the ER, the checklist that you can follow for the management of acute pancreatitis: you start oxygen therapy if the patient is hypoxic, you give IV access and you send the labs, you perform ABGs, you give the targeted IV fluid, you do not over aggressively resuscitate the patient, you give electrolytes as needed, especially the calcium levels, you give analgesics, antiemetics, you obtain ultrasound and CT scan only if there is diagnostic uncertainty, and you assess the severity, you apply those criteria. Urgent consults are taken if they are needed from gastroenterology and ERCP if there is cholangitis, and you consult the general surgery department only if there is severe acute necrotizing pancreatitis where there is so much necrotic tissue, and that general surgical department will open up the abdomen and take out the necrotic material. But remember, that procedure is associated with high mortality. A conservative approach is a better approach in patients with acute pancreatitis. You admit the patient to hospital, you consider ICU admission if there is severe organ dysfunction. So this is all a checklist that you can follow in patients with acute pancreatitis. Indications of ICU include patients with severe acute pancreatitis with all these things. These patients are unstable, these patients have organ failure, and these patients must be admitted to ICU. Coming to local complications, in the local complications, acute pancreatic fluid collection can occur, but that pancreatic fluid that is visible on CT scan resolves spontaneously. It does not need any drainage. Necrotizing pancreatitis is also a sterile fluid collection, and that also can be treated conservatively. If that fluid gets infected and there is bacteria in it, then CT scan will show gas within the pancreas. In that case, antibiotics are needed. Carbapenem, meropenem are the main drugs that are used. A 1 gram IV TDS are given, and if further the patient deteriorates, you send them to general surgery department for necrosectomy. And preferred is that you stabilize the patient first and then you send for acute necrosectomy, because if the patient is unstable and if the patient is having severe acute pancreatitis, in that case, if you open up the belly, there is high mortality associated with it. Walled-off necrosis occurs after 4 weeks, and you diagnose it with CT scan with IV contrast. Now remember, in all these complications, we are using CT scan. So you reserve the CT scan only for the complications. Walled-off necrosis is drained with percutaneous drainage or transmural endoscopic necrosectomy. You drain out the fluid if there is a walled-off cavity containing fluid in it. Systemic complications of acute pancreatitis include shock, surge, sepsis, DIC due to the inflammation and inflammatory mediators present in the blood. Pneumonia, respiratory failure, ARDS is an important complication, pleural effusion, pre-renal failure, volume depletion, hypocalcemia, paralytic ileus, and pancreatic ascites. Everything makes sense now when you know the pathology and pathophysiology of acute pancreatitis. Coming to the prognosis, mortality without organ failure, if the patient is having no organ failure, the mortality is less than 1%, and if the patient is having organ failure, the mortality is almost 30%. Important predictors of severity: age greater than 55, GI bleeding, fall in hematocrit, hypocalcemia, hyperglycemia, elevated inflammatory markers, evidence of organ failure. If these things are present, it indicates that it is more severe. These are the same things that we used in those criteria, the Ranson criteria, Apache criteria. They also use these markers, and if these things are elevated, it means that the patient is having severe pancreatitis. Before going into the summary, if you liked my video, please click on the subscribe button and check out my other videos on gastroenterology lectures and emergency medicine lectures. The link of those videos is given in the description below. We discussed that what is acute pancreatitis, what is the etiology of acute pancreatitis, the pathophysiology, and the multi-organ failures that occurs due to acute pancreatitis, the symptoms and presentation, examination findings, how do you diagnose it, how do you determine the severity, the labs that are performed, CT scan only for the complications, the labs of acute pancreatitis, inflammatory markers, important points, how do you assess the severity with these all grading criterias, in which the Ranson criteria is the most important one, fluid replacement being the most important one. You keep monitoring the patient with these labs, you correct the calcium levels, for pain control you give opioids, you give antiemetics, you keep the patient NPO, but you start the oral diet as soon as possible. As soon as the patient feels hungry, you start the oral diet. Antibiotics are not needed. Underlying causes must be treated. A checklist for the management, local complications, systemic complications, and the prognosis of acute pancreatitis. If you liked my video, please click on the subscribe button and check out my other videos on emergency medicine and gastroenterology lectures. The link of those videos is given in the description below. Thank you very much.